Hi everyone. So my topic is on hypercoagulability. So the picture over there is just to give you guys a brief overview of what I'm going to talk about in the next few slides. So you have your background and some of its complications, as well as its courses where it can be primary, secondary, and primary can be due to inherited disorders, and secondaries can be due to acquired disorders, and your management. So the definition, hypercoagulability or thrombophilia is just referred to um, increased tendency to develop blood clots due to the presence of one or more predisposing factors which can be inherited or acquired. And a normal and healthy response to bleeding for maintaining hemostasis involves the formation of a stable clot, and this process is usually called coagulations. And it is a good thing because it ensures the body to patch up and heal lacerations and injuries. However, if the blood is clogged or developed within the blood vessel, then it becomes problematic because it can put the patients into risk of developing thromboembolic events such as deep vein thrombosis or pulmonary embolisms. And deep vein thrombosis is referred to when the clot is developed in the deep vein of the lower extremities or upper extremities. The patient may usually present with pain or swelling in the affected limbs, and uh, sometimes part of this venous blood clot can break off and travel to the lung, and that's where it became pulmonary embolisms. And hypercoagulability describes the pathologic stage of exaggerated coagulations or coagulations in the presence of bleeding. And its etiologies, one of them is primaries, and this can uh, due to inherited clotting disorders in which there is a defect in the natural anticoagulant mechanisms. So some of the inherited disorders include the following: factor V Leiden, prothrombin gene mutation, prothrombin C and H deficiency, antithrombin 3 deficiency. And factor V Leiden, as some of our previous presenters have been talked about in detail, is one of the most common cause of hereditary thrombophilias. And normally, protein C regulates the coagulation cascade by inhibiting two factors, and that is factor V and factor VIII. And in factor V Leiden, mutations in the gene coding for factor V causes resistance to the anticoagulant effects of activated protein Cs, and this lead to unregulated productions of thrombin and consequently um, can increase the risk of clotting formations. And for antithrombin 3 deficiency and protein C or proteinase deficiency, this uh, inherited effects or that is secondary to systematic disorders such as decreased productions, especially in liver disease, and increased loss of protein through the kidneys, such as in nephrotic syndromes or consumption by active thrombosis. The other etiology is secondary, and this is caused by acquired factors or conditions that can increase the risk of thrombosis. So acquired disorders include following: cancer, smoking, obesity, pregnancy, major trauma or surgery, inflammatory or autoimmune disorders, prolonged immobilization, medication such as oral contraceptive medication. So for cancers can cause hypercoagulability through increased productions of procoagulant factors and cytokines, as well as through the interactions of malignant cells within the inner lining of the blood vessels. And for smoking, inflammation, surgery, or traumas, these can cause damage to the blood vessels, triggering the persistent activation of the coagulation cascade. And additionally, inflammatory disorders can cause systematic activation of the coagulation cascade. So it can decrease the natural anticoagulant mechanisms and causes impaired removal of blood clots. And antiphospholipid syndrome, this is one of autoimmune disorders that can cause by the presence of autoantibodies directed to phospholipids, which are the components of the cell membrane. And most frequently, lupus anticoagulants, anti-cardiolipin, and anti-beta-2 glycoproteins are the antibodies that's found within these syndromes. And individuals with antiphospholipid syndromes, they usually have a high risk of developing the atrial and venous thrombosis, as well as obstetric complications such as miscarriage. And for prolonged immobilizations, this can worsening the hypercoagulable state by slowing blood flows in the vein, especially in the lower extremities, therefore putting the patient into risk of having a deep vein thrombosis. And for medications, estrogen is one of the medication that can increase the risk of can increase the levels of coagulant factor 7 and 10, as well as decrease the level of anticoagulant proteins. And heparin is the other medications. This can induce thrombocytopenia or low level of platelets, and this is an acquired thrombophilia that can be seen in some individuals who are taking heparins, and heparin is commonly used to prevent the development of thrombosis in hypercoagulable states. And heparin is also induced an immune reaction that triggers the activation of platelets and the release of procoagulant cytokines. And these changes can lead to formations of thrombi in blood and low platelet counts due to taking too much of it. And its clinical features, one of them is venous thromboembolisms. This is one of the most common clinical features. So the example of venous thromboembolisms are deep vein thrombosis, pulmonary embolisms. And the other clinical features is atrial thromboembolisms. And this is usually an acute event that can result in ischemic tissue damages. For example, someone who has a stroke, or acute mesenteric ischemia, acute limb ischemia, acute coronary syndromes, and pulmonary infarction. And how are we going to diagnose these conditions? Family history is one of the very important diagnosis. So taking a history from the patient is very important. Someone who has a family history of thromboembolism should be highly suspected of this condition. And the other one is doing a laboratory studies, and one of them is doing a coagulation studies, which can determine the active partial thromboplastin times, which is usually prolonged in someone with a antiphospholipid antibody syndromes. And the other one is antiphospholipid antibody panels, and the other laboratory studies is hypercoagulable panels, which can help you to determine its active protein C resistance, factor V fladings, prothrombin genes, and the level of protein CNS, as well as the antithrombin heparin cofactors. And the treatments, so how are you going to approach these patients for a patient to develop or having a pulmonary embolisms or deep vein thrombosis? You should give the patient should administer or prescribe a anticoagulant, the heparin bridge to warfarins. However, if it was contraindicated, then they should give inferior vena cava filters. And some of its approaches is to reduce the risk factors, such as try and avoid taking oral contraceptive pills, especially for women who are greater than 35 years of age, and as well as try and quit smoke, or try and exercise regularly to reduce weight, especially for patients who are obese or overweight. And some of the special consideration you should take notes while treating the patients is for heparin. Heparin is really contraindicated in some other patients because heparin, it usually induces thrombocytopenia type 2 and agathrombin or lepidolin should be prescribed instead of prescribing a heparin for the patients. And heparin is less effective in antithrombin 3 deficiency. And those are my references, and that concludes my presentation. Thank you.